great pleasure and honor to have Cecile Viboud give us the first keynote talk today. Cecile is a senior research scientist in the Division of International Epidemiology and Population Studies at the Fogarty International Center at NIH. The research focuses on epidemiology and transmission dynamics of acute viral infections and the interface of public health and computational modeling. Her work has concentrated on modeling the epidemiology, mortality, and transmission dynamics of respiratory viruses, including seasonal influenza and COVID-19. She has recently become interested in the potential of big data to strengthen infectious disease surveillance, disease forecasts, and population-level impact of vaccination programs. She's a native of France. She received a degree in engineering in biomedical technologies from University of Lyon, and Masters of Public Health and a PhD in Biomathematics from Pierre Curie University in Paris. She joined NIH in 2003. And we have interacted with Cecile for a long time. And Cecile, I'm a great fan of your work personally. I absolutely remember the work you and Brian Grenfell published in Science on these waves and synchronizations or lack thereof. Cecile has been one of the leaders in the CDC scenario modeling hub work that Alex, Kat, and others are co-leading with her. But pleasure to have you, Cecile, and the podium is yours. Thank you very much.
Well, thank you very much, Medha, for the invitation and the opportunity to interact with this group. I didn't know anything about this expedition project, so I'm excited to hear more. It's also great to see such a diversity of expertise. So today, I wanted to talk about the indirect consequences of the COVID-19 pandemic. Yeah, so we've all lived through two pretty amazing years. And obviously, the pandemic had far-ranging consequences on behavior, but also very different health conditions. And so I just want to illustrate this through several studies that we've done recently, touching on changes in healthcare utilization and mortality, both for infectious and chronic conditions, as well as the impact of COVID-19 on the circulation of endemic pathogens, where basically circulation has been perturbed for 2 years. And so what should we expect next in the coming years? And so I will illustrate those aspects with studies from the US and South Africa. At the Fogarty International Center, we're very focused on global health, so we try to work with a lot of partners in LMIC, and South Africa has had a lot of very interesting data and good surveillance throughout the pandemic. And so methodologically, those work touches on a variety of statistical and mathematical approaches. So starting with the impact of the pandemic on mortality and healthcare use. So if we think of the mechanism of mortality during the pandemic, they can be threefold, and they can include direct consequences of the pandemic or viral infection, indirect consequences, or no consequences. So I'll go through those three mechanisms in turn. So if we think of the direct consequences of the pandemic, we're thinking of the impact of SARS-CoV-2 infection. And so there are two options following a SARS-CoV-2 infection that triggers death. Either the death is recorded as an underlying COVID-19 death on the death certificate, and the algorithm for those will depend probably on the country, on the state, and on the time period of the pandemic. Or it might not be recorded as an underlying COVID-19 death, perhaps because no test was ever done, or when the test was done, it was too late. Or as we've seen even in the world of flu, sometimes you get an initial viral trigger event that exacerbates an underlying chronic condition, such as diabetes or cardiac disease. And so the ultimate event that leads to death is the cardiac condition or diabetes, so the chronic condition, and you never see the viral infection listed on the death certificate. So it's a problem we've had for a long time in trying to quantify the burden of respiratory viruses. But if you think of those direct consequences of the pandemic, you would expect that there would be synchronicity between mortality, perhaps from respiratory conditions or chronic conditions, and COVID-19 activity. If we think of the indirect consequences of the pandemic, again, there are multiple pathways. One is through the healthcare system, whether the system is saturated. For instance, around the peak of COVID-19 outbreaks, there were many reports of saturation in the first wave of the pandemic, including in New York City. Or people maybe just avert the healthcare system during COVID-19 for fear of being infected. There can also be depressed circulation of endemic pathogen. We'll go back to this towards the end of the talk, but clearly, if you have depressed circulation of those pathogens, that's going to tend to decrease mortality. And then there are also societal consequences of the pandemic. A lot has been written about the rise in violence, but you can also think that there might be impact on suicide, opioids. And there you're not necessarily thinking there would be such a tight synchronicity with COVID-19 activity because those are sort of indirect pathways. Perhaps there could be synchronicity with interventions or other factors that are perhaps more difficult to measure. And then, of course, there could be some conditions for which there is no consequence of the pandemic and mortality proceeds similar to past years. And we're going to see examples of those three different pathways, in particular in the US data. So we've looked at weekly deaths in the US, both nationally and by state, by age group, and for the underlying causes of death that you see listed here. So a range of chronic conditions such as diabetes, Alzheimer's, cerebrovascular disease, heart disease, and cancer, as well as respiratory and COVID-19, which is sort of our most specific indicator of what the direct impact of COVID-19 is. And then something that's quite interesting, it's called external causes of death, which is the sum of deaths from opioid injuries, homicides, and accident. So a type of condition for which we would expect most indirect pathways rather than direct pathways of death. And then we've run through two-stage attribution approach to try to both estimate the change in mortality during COVID-19 and attribute them to some drivers. So first is to estimate weekly excess mortality. So excess mortality is an approach that has been used for many, many years in the world of respiratory viruses, particularly flu. It was used back in the 19th century in the UK to look at the impact of the first few pandemics. But the idea is that you use the data from past year before the pandemic to fit a baseline mortality. Typically, if you think of respiratory infection, the baseline is seasonal. And then you look at mortality during the pandemic season, and then you can do the difference between observations and projections if the pandemic had not happened. So that's how you get excess mortality. And then in the second stage, we regress excess mortality on a weekly basis during about 90 weeks of the pandemic, 2020 through 2021, against indicators of COVID-19 and interventions. So this is an example of some of the time series we have on the left for the US as a whole and then by state. I think everyone knows in this room that the pandemic had very varied impact geographically across the US, but this is just to illustrate some of that. On the right-hand side, the vertical red line marks March 2020, which is the beginning of what we consider the pandemic and its impact on mortality. But you can see that in places such as New York, in the middle right, we see that the major impact is during the spring 2020 wave. But in contrast, if you look at Texas, for instance, there's a more balanced impact of three waves during 2020 and 2021. And then California is behaving differently. It's in the winter 2020 to 2021 that has the major impact. And of course, if you're looking at the US as a whole, you're averaging out all of those different patterns at the state level. So the red line is the observation, and then the blue line is the seasonal baseline. And here we're looking at total mortality, so our most inclusive indicator. And so again, excess mortality will be the difference between the black and the green during the pandemic period. There's also a confidence interval under there, which is in orange, but it's so tight you can't really see it. So the first thing we can do with this excess mortality approach is try to validate the statistical approach for what we think is the impact of COVID. And one way is to try to calibrate it against independent indicators of attack rate. So we're using seroprevalence surveys that are compiled by the CDC, which you see on the graph on the right. So the seroprevalence in the population in the middle of 2021 is on the x-axis, and then we can contrast that against estimates of excess respiratory deaths. So what we think, again, is the most specific indicator of COVID-19. You can see that there's a pretty good relationship between those estimates. There is a clear outlier, which is New York State. And we've learned since that the serologic assay that they've used in New York has actually a lot of waning. I think we discovered that through our COVID-19 scenario modeling project, but that definitely explains what we see in this data. Basically, there are seroprevalence declines over time. And so that's why they look like an outlier. But overall, we find an infection fatality rate of 0.6%, which is in line with what other studies have shown. And of course, if you just look at the people older than 65, the infection fatality rate rises a lot. But that shows us that our excess mortality approach is probably quite good at capturing the impact of COVID-19. So here we're looking at trends in mortality and excess mortality across different conditions. So on the top left, we see all cause, which is total mortality. And here we see the impact of 4 main waves of the pandemic. The first 3 waves here are associated with the original Wuhan strain. And then the wave that you see in the middle of 2021 is the Delta variant wave. And here we stop in December 2021, just before Omicron. Just looking at the timing of those peaks in total mortality, we can assume that a lot of it is going to be synchronized and strongly related with COVID-19. If we look at the time series for respiratory and COVID, which is the second to the left, top row, we also see those very clear 4 waves of infection. And that lines up very well with COVID-19 activity as provided by other statistics. And then what's quite interesting is to look at some of the chronic conditions, for instance, Alzheimer. And with Alzheimer, you also see the peaks of mortality that line up quite well, especially the first 3 peaks of the pandemic, which line up both in time but also in magnitude. And then we also see a peak in the middle of 2021. However, it's much attenuated. And we think here we get more of a disconnect with COVID-19 because of the impact of the vaccination program. Diabetes is behaving the same, where we see the 4 peaks of mortality, heart disease as well. Cerebrovascular disease has a little bit also, but is less tightly connected. Interestingly, with cancer, we do not see any change in mortality beyond the expectations. So the expectations as before here are in green for the baseline, and then orange is the confidence interval. So you see that the observations don't really fall outside of the confidence interval for long periods of time. And then external cause is a pretty large excess of what the baseline would be expected. And we'll return to that in a second. So once we have some of those curves, we can calculate excess mortality on a weekly basis and try to relate it with indicators of COVID-19 intensity and interventions to try to see how much of this excess is due to direct versus indirect consequences. So this is what we're trying to do here in this slide, where we see the result of a relatively simple model where we explain weekly excess mortality as a function of interventions for which we use the Oxford Stringency Index, as well as COVID-19 intensity, which is COVID-19 case counts. And the red dots represent the model estimates, and then the black dots are the observations, so straight from our weekly excess mortality models. We're looking at this across all conditions that we were interested in before. And the blue estimates that are on top of each graph represent the contribution of each driver, which is in blue COVID-19 and then in green interventions. So we see that for all-cause mortality, most of the excess that we find is attributable through this statistical approach to COVID-19 activity. So 85% of all excess death over 2 years would be due to direct SARS-CoV-2 infection. But we also see an impact of COVID-19 on diabetes, about half of the excess death, Alzheimer's, 63%, cerebrovascular disease, about a third, heart disease, 80%, but pretty large confidence intervals. We can't attribute anything to cancer. Neither COVID-19 activity nor intervention seems to explain very much. And besides, we haven't seen really changes in cancer. And then external causes of death, here we see that the main driver is interventions rather than COVID-19. We don't see any statistical relationship with COVID-19. However, the model doesn't fit the data terribly well. I mean, it's not bad, but it's also not great. And also what we see when we look at the timing of the relationship, it's that it's the change from pre-lockdown to post-lockdown. So in early 2020, that really affects this model where we have most of the signal and the change in external causes that's due to interventions. We've also done additional synchronicity analysis where we looked at again, the weekly correlation in some of those time series before the pandemic and after the pandemic. And we see that the pandemic has synchronized a lot of those causes of death. Again, speaking to the broad impact of COVID-19 on some of those chronic conditions. So during the pandemic, diabetes time series become more correlated with respiratory conditions than before the pandemic. This is something that we've also seen in past influenza pandemics. So we can also try to look at changes in external causes of death by subcategories. There's a bit less detail in those data because they tend to lag more, because autopsies have to be carried out before you can really assign a cause on the death certificate. But we can see the data up to about September 2021, and we can see differences in those subcategories of external causes of death. In particular, the biggest proportional change compared to past year is in assault and homicides. And it seems like almost every day now we see something about the rise of violence in the US in the post-pandemic period, but you do see that very clearly in those data. And you also see that those rises are not really timed with different outbreaks of COVID-19. They just tend to seem to rise in the summers, so summers of 2020 and summers of 2021. We also see a pretty large increase in drug overdose, plus 16% compared to past years. I will also note that some of those time series are not stationary at all, so fitting a baseline can be a little bit tricky. We're only showing a few years here, but we're fitting to more data from the past, just to get it to be a bit more stable. And then we also have rise in accidents and injury, plus 12%. And this is also the condition that represents the most deaths across all of these conditions that we see here. Interestingly, we don't see any change beyond the baseline in suicides, which I think it's good news. However, those data ended September 2021, and you can see at the very end of the suicide time series in black here that it seems maybe to rise a little bit, so we have to keep watch of that. But mostly the great rise that we see in external death is in assault and homicides and drug overdoses. We can also look at different age groups, because again, you can think the direct and indirect balance of consequences might shift in different age groups. Clearly, this pandemic is affecting older people more than younger people. So that's a rationale for trying to look at age. So here we look at 6 age groups from the youngest top left to the oldest bottom right. And we're looking at trends in all-cause mortality, and the data are in black as before. And then the green is the baseline and the orange, the confidence interval. So if you just look at the under 25, you see these clearly a rise in mortality above the baseline, but they don't seem to recapitulate the 4 waves of the pandemic that we know well, but instead they seem to align more with the patterns that we saw in external death, with a rise in both summers of 2020 and 2021. And then we can fit the same kind of attribution model that we've discussed before, and where we see that most of the drivers of those excess are attributable to interventions, with COVID-19 representing only 11%, so the direct impact representing only 11% of those deaths. In the 24 to 44 years old, we see more of an intermediate pattern where interventions are still predominant, but COVID-19 represents about 23% of those deaths. And now you see that these little spikes here of the increase line up more with the timing of COVID-19 outbreak. And then starting at age 45 and older, the major impact of excess mortality becomes the direct consequences of COVID-19 and SARS-CoV-2 infection, ranging from 62% in the 45 to 64 years old to 89% in the 65-74, and then it keeps increasing. What is quite interesting is that the model wants to attribute more excess death than we're finding in the 75 and 85 and older age groups, so 125 and 135%. And in one way, it could be just a statistical fluke that the model is not fitting well, but actually we can also try an independent comparison. We can look at all of the deaths that have been officially attributed to COVID-19 in these different age groups and compare them with our excess mortality approach. And there again, we see the same type of pattern where we attribute more excess death to COVID-19 that we have found in the data. So it suggests that our baseline is inflated for those age group. And it could be because of two phenomena that are not mutually exclusive. One is that we haven't accounted for the fact that other endemic pathogens have been depleted. And so mortality from those pathogens has also decreased. The model adjusts for circulation of influenza, but we can't adjust for every pathogen that's circulating out there because we just don't have proxies and indicators of activity for all of those pathogens. So that's one possibility. And then the other option is the idea of harvesting, which has been put forward for major health events, including heat wave. When you have a really large event that takes away a large fraction of your population, they might take away the frailest first. And then you're left at the end of that outbreak with a population that's healthier and dying less than the whole population a few weeks earlier. And we think we might perhaps see some evidence of this harvesting effect at the end of this big wave here in summer 2021, where we see that the observations start to fall below the projected baseline. And we see this even more clearly in the 85 and over. And it would make sense that those phenomena would be even more pronounced in age groups that are at highest risk of dying of COVID-19, which are the oldest age groups. So overall, we see that the majority of excess deaths from total deaths, right, our broadest indicator, from March 2020 to December 2021 are synchronous with COVID-19 activity. And hence, we can conclude that they are most likely the direct consequences of SARS-CoV-2 infection. So that's the majority of what we're seeing. But we also see excess mortality from multiple chronic diseases that are timed and synchronous with COVID-19 activity, and that can be attributed to the direct consequences of SARS-CoV-2 infection, but yet are not listed as such on the death certificates. And depending on the cause of death, it can range from 30 to 80%. What is interesting is that it persists throughout the pandemic. We still see a relationship in 2021. However, it's attenuated. And again, we think that's because of the impact of vaccination. And we have seen a similar phenomenon, although perhaps not as marked, but during the past pandemics, in particular the 1968 flu pandemics. We don't see that in the 2000 flu pandemic because it just didn't affect older people as much, and it was just a milder pandemic overall. So this is for the direct impacts, but we also see those indirect impacts, particularly among younger individuals and in external causes of death, and that's most pronounced in the summers of 2020 and 2021. And in a future refinement of the model, we're also going to try to adjust for healthcare utilization, and in particular to try to disentangle what we attribute to SARS-CoV-2 infection. Is this just that the hospital system is at saturation around the peaks of COVID-19 outbreaks? So I think this type of work is quite interesting. I mean, there are ecological analysis, right? So we can never say intervention caused death, and that's really not what we want to say, but we can see changes in patterns that seem to align with differences in behavior and try to understand why that is. As I said, it's difficult to estimate the baseline when so much has changed over 2 years, and fitting to past season can not always be enough. But I think it's also quite interesting as a natural experiment to try to understand what people die of in years when very little is circulating. And on the right here, I'm trying to illustrate this by showing you curves from respiratory conditions in 3 different age groups, 0 to 4, 5 to 64, and 65 plus. And this ends at the end of 2020. This is slightly more detailed than what I've shown you before, because we now have the final death certificates for all of 2020 that have become available. But just to illustrate that, if you look at the 0 to 4 and just focus on the red circle at the end of this, which is really when the pandemic arose, well, mortality from respiratory conditions, not COVID-19, really plummets in the 0 to 4 years old, but it doesn't in the 65 plus, right, or even in the middle age groups, right? So whatever pathogens are causing those respiratory deaths are still there during COVID-19, but not in children, right? So it's speaking to the etiology of mortality, which is very complicated to assess. And relying on the codes that are on the death certificate is definitely not enough to try to understand those pathways. I think what's quite interesting also in this work is that we don't see any excess mortality in cancer, which is an immunosuppressing condition. And, a lot has been said about how people with immunosuppressing condition are at particular risk for COVID-19. We don't see that. Is that because people with cancer were not exposed to COVID-19? They were shielded. They stayed home. There was a lot of attention to it. Or because truly having cancer is not a risk factor for increased COVID-19 deaths. The other thing to think about there is that the time lag for cancer between diagnosis and death is very long, right? And it's possible that some of the maybe undiagnosed cancer in 2020 and 2021 might only translate into deaths further down the line, and we haven't seen those. I will also say that in past flu pandemics, we haven't seen any rise in cancer deaths during periods of, for instance, high flu activity. So it might be something more general. And overall, I think pandemic preparedness plans should anticipate those indirect pandemic consequences, especially increase in opioid deaths, violence, and try to anticipate that and plan for that as much as possible. So we've looked at something related with data in South Africa, and this is a collaboration with the National Institute of Communicable Disease, which is more like the CDC actually. And so in South Africa, they have just been able to put together their private health system and digitize all of the records. So we've been able to look at a few years before the pandemic and then look at the impact of the 2020-2021 pandemic years. So on the top here, we're looking at admissions for respiratory conditions in South Africa. And in black, you see the observation, so the data. And then the blue is a seasonal baseline based on past years, adjusted for flu circulation. And then the green are the negative excesses or the averted cases. And then the orange are the positive excesses or the cases in excess, in positive excess. This is respiratory condition, so it does have the impact of COVID-19 here. And you can see that for children and up to the age of 20 years, actually the pandemic was a period where we saw less hospitalization for respiratory conditions than in prior years, possibly because circulation of the other endemic pathogen was depressed and COVID-19 didn't affect those age groups as much. And then in the 20 and over age group, we see 3 very clear peaks of pandemic activity, which line up with 3 different variants: the Wuhan strain, the Beta strain, and then the Delta strain. And then the graph at the bottom just represents periods of excess, both positive or negative, just again showing that in older age group, we see mostly positive excess, and in younger age group, we see negative excesses. So we can do this kind of excess approach across a range of conditions in South Africa. And here we're plotting in this histogram % change from baseline pre-pandemic years. And we see that all of those conditions decline during the pandemic, but the biggest declines are in asthma and intestinal infectious diseases. So for intestinal infectious disease, we can think that those infectious pathogens are not circulating as much. And then for asthma, there are also indications that some of the asthma crises are triggered by respiratory virus infection. So it's not counterintuitive to see those large declines. But we also see declines in diabetes, TB, myocardial infarction, cerebral infarction, and trauma and fracture. And so one question here is that we're only looking at the decline in hospitalization. And it is possible that if people averted the healthcare system because of fear of COVID-19, then these averted admissions might translate into increased deaths, either at the same time period or further down the line. And we don't have the excess death yet by specific conditions, but I think that will be something important to look at. We can also look at how interventions and mobility affect those changes in admissions for different conditions. So here are some of the indicators of interventions and mobility we look at. On the left-hand side, we see in blue the time series of activity for COVID-19 with the 3 waves, 3 different variants. And then the gray line is the Oxford Stringency Index. So South Africa applied very strict lockdown very early on in 2020, even though they didn't really have COVID-19 yet. And then they relaxed as COVID-19 started to increase. And then there was a second round of intervention during the beta wave, and then another round during the delta wave to try to decrease transmission. And then on the right-hand side, we see Google mobility indices, and in particular, the green index, which is the Google residential mobility, is quite nicely tied with interventions. So it's kind of how many people stay at home. So we can look at the weekly changes in admission for different conditions, which you see here in different panels, as a function of mobility. And here we're looking at Google residential. And we see that we have relatively strong relationship across all of those infections, with, in particular, a lot of change from pre-lockdown to lockdown, so the blue to the dark green dots. Interestingly, when we do the same thing for COVID-19 admissions, we do not see a strong relationship here. So that suggests that human behavior and interventions affect admissions for all of these conditions, but not for COVID-19 directly. So next, I will move on to a slightly different question, which is the impact of the pandemic on respiratory pathogens. And here, it's more about trying to understand whether the mobility has decreased circulation of those pathogens and what is the size of the immunity gap that we should prepare for in the coming years. So we're going to start with RSV, respiratory syncytial virus, which is a major respiratory pathogen, perhaps slightly less well known than flu because it doesn't cause this pandemic, but it is a very big pathogen, especially for young children, causes a lot of hospitalization and death. We really don't quite have a vaccine yet, although there's a lot in the pipeline. And there's also probably a large impact in older population that is more difficult to measure. Many countries monitor a circulation of RSV, and they've reported changes during the COVID-19 pandemic. In particular, low activity in 2020, and that was quite well reported in the Southern Hemisphere. And then when interventions were relaxed, large out-of-season RSV outbreaks. So we were quite interested to work again with our collaborators in South Africa because they had really good RSV data and also patterns of resurgence that were not entirely maybe easy to explain. So here we're looking at RSV surveillance data in South Africa. In gray, you see a few past seasons before the pandemic, 2015 to 2019, which is average in the blue curve. So South Africa is Southern Hemisphere. RSV is typically a winter pathogen. And so here, the RSV epidemics are actually a late fall pattern. And so they peak around week 15 to 16 of the year. And then in red, we see RSV detection, so proportion positive during 2020. And so we see that because of the lockdown measure imposed, the RSV epidemic in early 2020 was quite low, lower than usual. And then as interventions were lifted in the aftermath of that first Wuhan strain wave, RSV research, however, it didn't really match the size of a typical outbreak. It was also clearly out of season. By that point, it's spring here in South Africa. And then the patterns in 2021 are also interesting because while RSV, so that's in green now, while RSV starts as usual, then South Africa has to lock down again because of the Delta wave. And so circulation decreases. And so we were interested in trying to fit a transmission model to this data to see if we could reproduce what happened in 2020 and 21, and then project what would happen in 2022. So we can also look at the age patterns of hospital admissions for RSV. Again, this is a disease that's very focused on infants. And so here you see that most of those admissions are in the 0 to 2 months of age. But we can also try to compare what happened in 2020 in red and 2021 in green compared to past seasons. And we see a slight shift. It's not very pronounced, but it's there, of hospitalization towards older age groups. So here older is 6 months and 12 months, right? So slightly older babies. And there has always been a question in RSV and other respiratory virus system about whether if you get the disease in a more severe form when you're younger, is it because you don't have any immunity? Or is it because you're just young and you can't fight it off and perhaps your lungs are not as developed? But here, because we see this shift of hospital admissions and severity towards older age groups, it speaks to the fact that immunity is probably a driving factor rather than lung development, or at least matters as well, as much as lung development. So we fit a pretty classical SER model to this data. This was inspired by a model that's been used to model RSV in South Africa a few years back. The model is age detailed because, age is very important for RSV. So we have a lot of age groups here, especially for young children. We have maternal immunity for the first 2 months of life. We think that, it's a disease with a lot of waning immunity, and maternal immunity is not very long. And then the transmission rate, force of infection here, which you see in this equation on the left, has the classical form with a seasonal term and then a mixing matrix. And then the slight difference with prior iteration of RSV model is that we have a little c to measure the impact of interventions, right, in 2020 and 2021 that might have decreased transmission. So there's not a lot known about duration of immunity for RSV, and those models are actually not very sensitive to it. So we use a range of estimates from 2 months to 2 years, but in the end, I settle on a 4 months value, which seemed to fit the data the best. Although I would say there's quite a lot of uncertainty on this. And then some of the other parameters are either more well-known or easier to fit to the data. So these are the results of the age-specific model. The black lines are the observations, and then the colored needle graph is the projection in different age groups. And so we can see that the model is well able to reproduce the decreased circulation and decreased transmission of RSV in 2020 and 2021. And the projection for 2022, which are highlighted by the red circle here, suggests that we should expect a rebound of RSV activity, so a peak that's higher than usual. We estimate that it should be about 30% higher. And also a little bit earlier, it should peak in April of 2022 instead of May of 2022, as in a normal year. But then, this is a short-term perturbation, and we're projecting that in future years, pattern will return to normal. We also estimate that the 2 periods of lockdown in South Africa translate into a 47 and 37% reduction in RSV transmission through the various interventions that have been put in place. So when we did this project, it was February, March of 2022. And so our colleagues in South Africa were pretty eager to get projections from this model. So we sent them the projections, and the colleagues in South Africa were able to warn the hospitals and had a few media campaigns around it. As I said, the interventions are not entirely clear for RSV because, we have immunoprophylaxis in the US, but it's very expensive. So South Africa doesn't have much of it. But at least the hospital are able to make space and be proactive for the influx of patients. And we have since heard that there has indeed been quite an influx of RSV patients, although we don't quite know whether it's exactly what the model predicted. But at least we were right in terms of the timing of RSV resurgence. So we can also look at how those hospitalizations should translate in different age groups. Blue is for past years before the pandemic. Red is for the 2022 projections. And we can see that overall it's about a 30% increase over baseline, but the relative increase is a little more pronounced in older age groups. Again, because we think of the gap in immunity in those older age groups. So we have also tried a sensitivity analysis with a different model. So we're doing this with colleagues at Princeton University. And so TSIR, time series infectious recovered model is very widely used there. And it has been used for RSV too, in particular around COVID-19 and to predict the resurgence. But we can show here that it's quite unrealistic. So the main difference between TSIR and the model we have is that there's no waning immunity in TSIR. So you get lifelong immunity. This was developed originally for measles. And so we can see here the projections of this TSIR model in red versus the observation in black. So it does capture the past patterns right, but it predicts a very, very sharp peak in 2022, which is not borne out in the data. I mean, we haven't seen the exact data, but it's not as much as this. And also it all kicks the system into 2-year cycle, which so far we haven't seen, although maybe it's early on. But I think, you really need waning immunity in this model to try to reproduce the patterns. And the model also estimates a smaller reduction in transmission due to COVID-19 interventions. So overall, we project that severe infection would shift to older age groups, and we've seen some evidence of those patterns. I think the data is just accumulating globally to try to understand those resurgence, but we've seen some of those patterns in France in particular, where it's older infants that get the brunt of RSV in the post-COVID-19 period. So that suggests that RSV infection severity is influenced by prior immunity as much as it is by lung maturation. I think it was quite useful to get these projections done in real time so that the hospitals in South Africa could at least be warned about it. And so I think there's still quite a lot of uncertainty about the duration of immunity to RSV, which I think will become important in the long run as we try to move towards vaccination and more widespread prophylaxis. So I think trying to nail this down will be quite useful. But the last project I wanted to tell you about is also about the rebound of endemic pathogen, but closer to home. It's in the Seattle area, where we are doing a quite deep surveillance study that's been in place since 2018. So pre-pandemic, funded by Gates Venture. The idea was, how do we put a lot of money into surveillance to prevent a pandemic? Well, they could not prevent a pandemic, not surprisingly, but they were able to monitor it pretty well. So that's something. And it's doing surveillance through hospitals as well as the community. So for hospitals, we're using a lot of residual samples, so samples that have already been tested just for regular hospital purposes. And then through community, we're doing prospective surveillance of people with respiratory illness. And throughout the study, I decided that it would be good for people to self-swab so that they don't have to go to the doctor or to a hospital facility to get tested. So you register online, we check that you have some symptoms. We send you a swab by rapid carrier. You swab yourself, it's sent back to the lab, tested for 27 pathogens, which are listed on the right here. And then the result is returned to the patients within 24 hours. Through the studies, there's also increased sequencing, and in particular, Trevor Bedford is one of the PIs on the project. And the study identified one of the first SARS-CoV community cases in the US. I mean, they were really good at testing early as well as testing in nursing homes while nobody was doing that. So I think, just because a lot of things were in place, they helped a lot Seattle control their outbreak. And so the idea is to try to use this data to look at citywide transmission dynamics before the pandemic, during the pandemic, and in the post-pandemic period, and particular try to understand pathogen rebound. So I'll go a bit quickly here, but basically the data comes from a lot of different sources with lots of different sampling, and it's quite difficult to try to reconstruct incidence. So we try to adjust for age, the presence of symptoms or not, and whether people are sampled in the hospital and in the community. And we use person positive rather than numbers just to address variations in testing volume. The graph on the left here represents our patients from Seattle Children's Hospital and the different codes that those patients are seen for before the samples are sent to us for further testing. This is just to show that during the pandemic, there's been a lot of testing for COVID-19 just before surgery and procedures not related to respiratory symptoms. So there's also a change in and sampling over time due to COVID-19. And on the right-hand side, we see reconstructed incidence time series for 3 pathogens, RSV, rhinovirus, and strep pneumo, combining data from community and hospitals. And just to point out that during the COVID-19 period, so on the right-hand side of this graph, besides COVID-19, 2 pathogens are continuously circulating, and that's rhinovirus and strep pneumo. In contrast, a lot of the other pathogens, such as influenza and RSV, have disappeared in this population and only started to rebound just basically in 2022. So quite a late rebound in Seattle. We've also tried to beef up surveillance for respiratory symptoms in the Seattle area. So we're working with Outbreak Near Me here to do this, because it turns out that with participatory surveillance and systems that are really covering the country nationally, it's quite difficult to get a large enough sample size at the level of a city. So we try to recruit more people to participate in this project within Seattle. And you see here the number of participants before on the left and after we were involved. So this is October 2020, January 2021. We basically gave people a lot of Amazon gift cards so that they would report their symptoms on a weekly basis. So they're not testing in this system. It's just to get a syndromic indicator of influenza-like illness. And on the right-hand side, you see participants over time. So each row is a participant. And what's interesting is that we see the same participants coming back, which is what you like to see in those systems. We can also look at symptoms in this data. So on the left-hand side here, you see a heat map of different symptoms for the beginning of 2022, so which lines up with the Omicron wave. And not very surprisingly, you see a lot of symptoms in January, which is when Omicron peaked. And we can also line this data up with other indicators of COVID-19, and we see that those work well. So one of the interests in this project is now that we have all of those nice incidence time series for these different pathogens, we want to try to relate them to interventions and mobility. So this is one of the data sets we're using quite a lot, which is SafeGraph, which has a lot of detailed information. So here we're looking at SafeGraph movements within the greater Seattle area, so the scale of a city at different time points. So February 2019 is a nice control study of changes in behavior, but due to a 2-week snowstorm. And then March 2020 is the lockdown period where we see that very much movement have decreased. The Delta wave in July 2021, where things have rebounded a little bit, and then November 2021, which also coincide with an increase in COVID-19 incidence. So here's what we're trying to do by linking some of those epi data with population movements. And it's a bit of a busy slide, but I'll try to go quickly here. So on the left-hand side, we have the disease data. So we have flu, the top, RSV, rhinovirus, and SARS-CoV-2. And this is covering a year before the pandemic and then the 2 years of the pandemic. The blue curves are the estimate of RT, the transmission rate over time. And then in the background, you see the incidence time series. And so for flu, we're looking at RT for each of the subtypes of influenza. For RSV, we're also looking at the 2 types of RSV, A and B, and then rhinovirus is actually 100 different serotypes, so we're just combining them together because we don't have more resolution. And then at the bottom, we have SARS-CoV-2. But what's interesting in those data, if you look around the time of the state of emergency, so March 2020, you see a precipitous decline in RT for both influenza, RSV, but also rhinovirus, as well as SARS-CoV-2. So there's a very quick decline there in all of those pathogens. To measure population movement and mobility, we can again turn to SafeGraph as well as some of the Google data. And here is sort of a time series summary of the SafeGraph data. The top shows the within city movements and inflows in and out of Seattle. And in particular, the purple line is quite interesting because it's the number of visitors coming into Seattle from out of state. And you can see that it really plummets during the lockdown. So that's the orange period here. And then it resurged a little bit in the summer of 2020, but really not quite to the level that it was before. And it's really not until the summer of 2021 that visitors rebound and actually exceed what we've seen in some of the past years. And the visits to point of interest at the bottom is also quite interesting. In particular, if you look at the transit data, well, everything crashes during the lockdown, but some of the patterns that we see in the later part of this time series, in particular in January 2022 during Omicron, suggests also that people didn't use the transit as much, either because they were stuck at home with COVID or just try to telework. But you can really try to look at the behavior of this population here for those indicators. So we can try to link these indicators of population behavior with epidemic index through different methods. Here, this is using just simple cross-correlation. across rhinovirus, flu, and RSV. And just to keep things simple, we see that a lot of those things are correlated, but the indicators that work the best are really just what is the proportion of people staying at home and how long they're staying at home for. That's just the best indicator. We can also look at how those behavioral variables change over time in their relationship with epidemic transmission. And so we're using time piecewise lasso regression to look at the effect of those variables. And we're looking at 2 weeks forecast here. So this is for rhino. The green curve is the RT estimate using various autoregressive approach. And then the blue model is a prediction of RT just using the safe graph data, which, as you see, the blue is not very good, right? It's not very good as compared with the green, and it's always lagging, suggesting that actually those predictors are not enough to predict changes in RT. Well, what's quite interesting with this approach is that you can see broad changes over time. So on the left-hand side here, we're looking at the impact of autoregressive coefficient in this sort of piecewise regression over time. And for this autoregressive coefficient, we see that an 11 to 13-day lag is the best predictor of RT, which matches with the relatively long serial interval of rhinovirus. And then for the safe graph coefficient of the right, you can see changes in which coefficient are associated in different periods, and particularly when stay-at-home restrictions are lifted in July 2020 in the Seattle area, we saw a shift from quite local indicators, for instance, schools, daycare, recreation, towards, for instance, influx of visitors from different counties becoming important, and then another shift in the spring of 2021. We can do the same thing for COVID-19, and it's quite difficult to see any predictor of COVID-19 activity. But if you look at the graphs on the right-hand side, the safe graph coefficient are really all over the place, and we can't really discern any pattern in the data, while the autoregressive coefficient make a lot more sense and sort of, again, match with the 7-day, match with the serial interval of COVID-19. So when we do this across pathogens, we see more predictive power of those behavioral variables for rhinovirus, flu, and RSV. But really for COVID-19, we don't really see any strong predictive power, and it's almost as if population behavior responds to COVID-19 activity rather than the reverse. And I think that's kind of what we saw in the South African data too, as well. And I just want to leave you with one last idea, which is about pathogen interaction. So we do see a lot of interactions during COVID-19 just because all of those pathogens respond to the same behavioral changes. But you can also think of other types of interactions which are immunological. And the top here represent the incidence time series for COVID in orange versus rhinovirus in blue. And you can see that they are nicely out of phases. They're also not independent because they're measured on the same samples. But you do see here potential for population level interactions. And we can also look at this at the individual level. And this is work done on this same Seattle data by people at IDM here. Very clever work where they've looked at the changes in CT values in people who were infected with a single pathogen versus people who were infected with multiple pathogens. And you see a graph of the CT values on the left here for influenza B, rhinovirus, SARS-CoV-2, and strep pneumo. And if we just look at rhino, for instance, which is at the top right, you can see that the CT values tend to be lower when rhino is on its own versus when it's with other pathogens. And if you speak CT value, a lower value means higher viral load, right? So it speaks to a negative interaction or an antagonistic interaction whereby rhinovirus is repressed by the presence of other pathogens. And you can test all pairwise interactions with this data set. The only interaction we can really look at during the COVID-19 period is those with strep pneumo and rhino because they've been circulating the most. And we do see evidence for these negative interactions, again, for rhinovirus that are statistically significant and positive interaction with strep pneumo, which here is in red. So in the pre-pandemic period, we also see quite a few negative interactions between viral pairs. And most of the interactions with strep pneumos are positive, suggesting that strep pneumoviral load is increased when it's co-infected with viruses. We haven't fit any population model to this data, but I think it will be quite interesting to try to resolve this, because I think if we want to see an interaction, it's probably during the pandemic when infections with COVID-19 were so prevalent in a large fraction of the population. So this is my last slide. I think overall, the pandemic had a profound effect on healthcare use and chronic infectious disease, and we're just starting to take stock of really all of those effects. But multiple pathogens have been suppressed or perturbed for 1 to 2 years. And I think the rebound patterns vary. They vary both between pathogens, but also between countries. But I think there's a lot to learn about the dynamics of this disease through that natural experiment. And what could affect those different rebounds include seeding patterns, whether the pathogen managed to get to remain locally persistent at very low level undetected versus it has to be reintroduced. For instance, we think that flu has to be reintroduced, and for that to happen, you really need the global network to rebound as well, not only just local movements. Persistence of immunity is certainly a big part of the size of those rebounds. And in the Seattle study, we're now doing a lot of serology to try to get at the size of the immunity gap during COVID-19. Seasonality will also affect some of those rebounds. Something that I didn't talk about at all here, but I think that will be quite important in LMIC is the gaps in vaccination, particularly childhood vaccination during COVID-19, that might translate into resurgence. And then differences with geography. And then the last point is about pathogen interaction, which I think is also a really fascinating problem, but a difficult one as well, but to think about both of ecological but immunological interactions. And with this, I will end and just leave you with a picture of people in the lab or associated with us. Thanks a lot.
Yeah, Cecile, thank you for that amazingly broad coverage. What are the implications for management? It's not just mobility, but mask wearing and all the other measures. If they suppress outbreaks of other diseases, in forest fires, one's learned that small outbreaks, controlled burns are probably needed, but I don't know if you do that with infectious diseases. What is this going to mean in terms of the buildup of susceptibility, and what would be the implications for management?
I think it really, at least masking, really opened the door for infectious disease specialists to think, we can actually do something, right, about transmission. I mean, it's so nice to have a season without RSV, but is that sustainable? I think we're relying on the behavior of the population, right, and what they are willing to accept. So, for instance, for the RSV model in South Africa, we have tried to ease intervention out in 2022 and 2023. What happens if you still had some low level of masking maintained for a while? And we do see smaller resurgences, right, and smaller outbreaks. So it is possible, but whether the population would be, amenable to do this in the long run, I think that's still a question. Asia has done it well since SARS, right? So I think.
No, I'm asking whether even it could be counterproductive to have masking and other measures that suppress small outbreaks for a while, but maybe set the stage for an explosion.
Yeah, well, I think suppressing completely is difficult unless you have lockdown. At least that's what we see with the South African data. And so I think it would be more like we would have some low level of circulation and lower transmission than usual. And if it's spread out over a longer time period, maybe you do not deplete susceptibles as much. But yeah, I think it's a good question. Yeah. And we could try, it might have different effects on different diseases also, depending on duration of immunity, etc.
Sure. Thank you very much.
One thing I was going to add in there, Cecile, just to echo on. With influenza, for instance, we were just talking about this during the scenario modeling hub, about excess mortality from influenza, for instance. And perhaps, as Simon was saying, like the forest fire of COVID has sort of maybe cleared out some of the more frail people in the population. So this fact that maybe we're suppressing this disease, but we're also potentially removing some susceptibility, at least of the most severe outcomes, might have this counterintuitive rebound as well. We were talking about this last Friday, and this sort of interplay, especially with all that really nice work on the excess mortality, I think is really interesting. And for instance, when you're modeling the South African rebound of RSV, I wonder to some degree if maybe some of the more susceptible individuals may have already been impacted by COVID, and that may actually impact future waves of RSV, for instance. And what that interplay is, I think, is really challenging to estimate. But I just wanted to get your thoughts about this excess mortality from some of these infectious diseases and echo from COVID we might hear in the future.
It's an interesting point. I think the frailty, to me, works better when you think of older age groups, right? Because, I mean, COVID is really affecting older age group, and those tend to be also the population that we think more of being at risk of being frail, right? I think for RSV, which is so much focused on young children, where infection rates with SARS-CoV-2 are perhaps lower, and like death from it is very low. I think I wouldn't expect that we've harvested frail children, right, from COVID. But I think your point about harvesting older people, frail people, because of COVID, and now we're left with a healthier population, is a good point. I also don't know how long it takes to replenish a frail population, because we keep having people who get diabetes or other conditions all the time, right? So,
That's another level of modeling we'd have to look at.
Yeah.
The actuarial replenishment of them, or
Yeah.
Hi, Cecilia. This is Anuj Mumbai. That was a fantastic talk, and you covered so many different examples from different diseases, as well as I really like your work on excess mortality. You are using this data of US and South Africa. Is there any particular reason for you using these countries as one of the things we are realizing nowadays is the data. How far we are like to have something like a weather forecasting for the disease forecasting? These excess mortality data, is it available for other countries, such as India, for example? There was a huge problem when Delta wave was, and the mortality was not even reported. How do you get this at a global scale?
Yeah, that's a great point. And the short answer is that we don't. Yeah, but I mean, there's a lot of question about what is the mortality impact of COVID-19 in LMICs in Africa, for instance. And, in all of Africa, pretty much South Africa is the only country to have vital statistics in place. And so that leaves you with a very difficult question to resolve. So people have been trying interesting approaches, such as, for instance, there was this nice study in Syria where they use Facebook groups where obituary are posted online, and you can do excess mortality on Facebook obituaries, and you see a very sharp peak of mortality, for instance, in the summer of 2020, in a country where almost no death is reported, or even satellite imagery in Somalia to look at how cemeteries changes over time. But that's very, very remote, right? And with little testing, it's just a very difficult question to answer. There has been some nice work done in India, actually, at the scale of a region or a city. And there are also efforts to do excess mortality globally using the vital statistics that are available. There's, WHO has one of these projects, and there's a really nice paper in eLife looking at that. And where you can look at about 100 different countries, and you see so much heterogeneity in excess mortality pattern, and also in what's reported as COVID-19 death. But yet, you have almost no data in low-income settings, right? So it's sort of the top of the countries where you do see interesting patterns there already. So yeah, I'm sad. I mean, I've been in this world for 20 plus years, and I see no progress in vital statistics registration. So I don't know what we should do, but yeah, the data issue is big.
And especially when the case count and these hospitalization counts are dwindling now, then they're not being frequently reported, and also some places are not even reporting now cases count. So the mortality is one of the good signal for that thing. But the question is, where do we find for remaining countries, not the developed one? So
I mean, I think the issue with mortality is now that almost 100% of the population, as in global population, has immunity either from natural infection or vaccination, you expect those mortality patterns to decline. And so it becomes much more difficult to measure the impact of COVID-19 as compared with the first 2 years, where you see these very clear signals. I mean, I think with flu, we always struggle to measure the impact. And it's granted, it's easier for flu than for other bugs. But it's always easier to pick up the signal of a very large event. But hopefully in the future years, there's going to be milder events. And so that makes it more difficult, which is why I think hospitalization data is a good indicator to keep going for. If we can have it, at least, in the US, that's what we are strongly hoping to keep monitoring and modeling.
Great. Thanks, Cecile. Really wonderful talk. So you had mentioned about lack of healthcare access. Can you elaborate a little bit more on what affects different parts, including the US?
One of the hypotheses is that people just averted the healthcare system during COVID-19 for various reasons. And that's on top of any issue to access healthcare that is pervasive and that's there before the pandemic. It's difficult to measure that, right? Because it's just stuff that's not seen. So unless you have surveys, it's hard to tell. There was in both the US and South Africa, there was a big push towards telemedicine, which is not included in those, traditional statistics of, for instance, hospital admissions, right, or GP visits. But we got some data from South Africa, and those telemedicine visits didn't explain all of the decrease that we saw in hospital admissions. So we still think that despite the rise of telemedicine, we still have decreased healthcare access during COVID-19. And to your question about the global aspects of that, I think that's going to be quite different in different countries, probably, depending on how they were impacted by COVID-19 and also what's their just baseline healthcare access in the first place.
Cecilia, you were mentioning about this interaction with other similar pathogens. Is the waning immunity for COVID also has a relationship with this other interaction with other pathogen? And if so, are there any other studies that have been falling at a global level, for example?
Yeah, so interesting point. So when we think of the immunological interactions between pathogens that are very different, like COVID-19 and rhinovirus, we're thinking of non-specific immunity, which is, interferon, cytokine, innate immunity that's not, specific to either of those pathogens, and that's very short-lived. When we talk about waning immunity to COVID-19, we think more about the specific immunity targeted at COVID-19, right? Our B cells, T cells, and the effect of that, which may wane over time. So I think the timescales are different. I think where you might be right is in thinking of the interaction between COVID-19 and seasonal coronaviruses, which I didn't talk about, but there's much more genetic similarities there. And there's actually some of the COVID-19 serological assays that react if you've seen seasonal coronavirus recently. And so I think there, the idea of waning specific immunity to COVID-19 might affect what you see in seasonal coronaviruses. So I think, yes, if you think of pathogens that are more closely related, but if you think of stuff that's really, really different, it's probably more about cytokine, maybe a week or two, when you're really infected and sick, and you have all of those immune mediators in your body.
Okay, thank you.
As a closing question, Sil, first of all, thank you for an absolutely fascinating talk. My question is really motivated because we have this amazing set of folks gathered here. And one always wonders, what is the level of sophistication one needs from a mathematical modeling standpoint? Many of the results showed really interesting, but use, as I understood, relatively simple mathematical models. Do you think that working in this area for so long, do you see the need for absolutely new class of mathematical models, or you see that access to more data would solve much of the problems? Because this is a continuing debate, right, in terms of whether we should invest in this collecting more data, or should we build more and more sophisticated models? And I would like to take your perspective.
Yeah, very nice question, Madhav. So I'm always going to be the data person. That's how I was trained. So I will argue for more data. And I think there's so much opportunities, both even just like on the epi side, right? I mean, we're talking about how we don't have any data from LMICs, for instance, in a lot of those things, but also the immune system and behavior. I mean, we've got more of those during COVID-19. I think we were lucky in a way, but there's just so much more than we need. And to me, that's the more crucial need, rather than, new computational approaches. But I could be wrong. I know, this audience is also probably more math oriented than I am. So, but my view is that we have such gaps in data. That's really the major frontier at this point.
I'm going to let Arushi close the session with.
So my question is, if you have a decreasing function of time t, which talks about the number of people in like a fixed population in a region that is masked, does that have a causal relationship with less deaths from a specific disease that you're trying to measure herd immunity or something for as a function of time?
Yeah, I mean, I think it depends how that function is decreasing over time, because infectious diseases are not continuously increasing or decreasing. I mean, they come in epidemic waves. And I think it's really the synchronicities of those patterns and the shapes that you're trying to get at. But yeah, if you think that masking has an effect on transmission of a bunch of pathogens, and I think we do think it has an effect, then if population decreases over time, that's going to affect transmission of those pathogens.
Thank you again so much, Cecile. That was fantastic.